Yeah, so identifying high-risk asymptomatic individuals remains the cornerstone of CVD prevention, and various scores are there, and previous speakers have already discussed about what I'm going to say. I'm just going to give a summary of that. So CAC score, that's what we call it as a coronary artery calcium score. It is done using non-contrast CT. The radiation for that is very less, cost is also very less. It's a highly specific marker for atherosclerosis, and it's used to assess patient management. Who should undergo? So 2019 guidelines say, ACC guidelines say, give a class 2A recommendation for intermediate risk and for some selected borderline risk. We never do it for low risk people. And again, so 2021 ESC guidelines also has given as a class 2B recommendation, and Society of Cardiovascular Disease or Computed Tomography Association has given, so also recommended for 40 to 75 years asymptomatic individuals with no history of atherosclerotic cardiovascular disease and with borderline or intermediate risk, and very, very selected low risk patients like when they have a family history of premature coronary disease. So with these things, there are various methods for identifying coronary calcium score, like we go for a volume scoring and everything, but most important method used is Agatston score. So it's a semi-automated tool where some density factor measured in ounce fields, that is the highest attenuation values measured, and then the area of the calcified speck is multiplied. So it's a product of that. So the ounce field units and the area occupied by the calcified speck, and then all that calcified speck areas are all total, and then we get the total calcium score. And based on this, we have either a 0 calcium score, which is no evidence of calcium plaque, 1 to 10 like minimal, 11 to 100 can be mild, and then not 1 to 400 or more than 400 is severe. And again, so interpretation will be like 0 is always happy to have that. It's very low risk, where the risk of myocardial infarction less than 1%. 1 to 100 is considered as a low risk. Risk of MI is less than 10%. And after that, it's 10 to 20 or more than 20 when the score is more than 400. And because why do we want to know the score? When calcium CAC score is 0, just reassure the patient. No need to give any statin. Lifestyle modification may be advised. When CAC score is 1 to 100, you may consider giving a statin or aspirin. When CAC score is more than 100, definitely you have to treat the patient with statin and aspirin. So this is one flowchart from ASVD risk stratification. Any patient with a low risk less than 5% lifestyle modification, and more than when the risk is more than 20%, that is high risk. So we go for lifestyle modification, high intensity statin, where LDL has to be reduced by more than 50%. But CAC score comes in this borderline and intermediate risk, where the percentage is 5 to 7.5% or 7.5 to 20% intermediate risk, where measuring CAC score is going to add on to value, because if it is going to 0, if the CAC value is 0, then without any family history of a premature cardiovascular disease, when patient is non-smoker, then just lifestyle modification is needed. If CAC score is 1 to 99 and the age is more than 55 years, then you may advise a moderate intensity of statin. And if the CAC score is more than 100, definitely you have to advise moderate intensity of statin. So reclassification of this borderline and intermediate risk group of people is done with the help of calcium scoring. So advantages are that it can be so any high scores are always associated with the elevated cardiovascular risk, so it gives a favorable prognosis, and it adds on to traditional risk calculators to correctly reassign or reclassify intermediate high risk patients to a higher or lower risk following calcium scoring. It also gives an estimate of vascular age of the patient. So pitfalls are that it cannot distinguish between obstructive or non-obstructive CAD. For that, you have to go for a CT coronary angiography, and does not provide information on the presence of burden of non-calcified plaque. So we had so non-contrast CT will tell us only about the calcified plaque, and calcium scoring is not routinely recommended for symptomatic patients. For symptomatic patients, if you have to go for a CT, you have to go for a CT angiography. So only for asymptomatic patients and intermediate risk, we advise calcium scoring. So having known about this, so let us go for other risk scores which are available. So we have this Framingham risk score, which is based on Framingham heart study. It is a gender-specific algorithm, and online calculators available. Estimates 10-year risk of manifesting clinical cardiovascular disease. It's validated for US population, both men and women, and it was published originally in 1998, then 2002. Current version is from 2008. based on this article published in Circulation. These are the parameters included, like gender, age from 30 to 74, total cholesterol, HDL, systolic BP, whether patient is on medication for hypertension, smoking, and diabetes as a parameter has been added recently from 2008. So this will give us an estimate of heart age or vascular age of the patient. And we classify them as a low risk 10%, less than 10%, or 10 to 20%, or high risk more than 20%. And here one pitfall is that we don't know, even diabetes was recently added in 2008, and again a family history of premature CAD is not taken into consideration, but by common practice, if there is a family history of premature CAD, we double the Framingham risk score. And QRISK-3 score. So this is specific for a UK population. So NICE guidelines recommend QRISK rather than Framingham risk score. This is it calculates a person's risk of developing heart attack or stroke over the next 10 years. So age usually taken years of 25 to 84 years. QRISK-3 is the most recent version of QRISK. Initially QRISK, then QRISK-2, now QRISK-3, because it gives additional, it takes into additional parameter like whether patient has CKD, migraine, whether he's on steroid, SLE, even mental illness, depression, atypical antipsychotics, and so all these parameters are added into this. So it gives a prediction algorithm for use the traditional risk factors like age, systolic BP, smoking status, and total cholesterol to HDL ratio. Then in addition, we have these other parameters also included, like as I said, steroid and mental illness, SLE, and arthritis. All those things are also, family history is also included, which was not then Framingham risk score, all these things. And so if the score is more than 10, so that means the risk of developing CVD is more than 10%, and primary prevention like lipid lowering therapy, statin has to be started. And it is uploaded annually, and every year it is updated also in the website. And we have other scores like renal risk score, which is more specific for women over age 45 years. Not very much validated because it's more, in the study it was mostly white women of middle socioeconomic status were included. Low risk women were not even much considered here. So it's not practically widely used. Then Bredick score is that it's more for New Zealand data. So it gives only 5-year CVD risk, whereas like Framingham and QRISK gives 10-year risk data. So again, it's not widely used. Then ACVD risk estimator plus is the most validated and widely used score based on 2019 ACC-AHA guidelines. And adults who are 40 to 75 years of age and should undergo this 10-year ACVD risk estimation. Initially it was ACVD risk estimator. Now it has been updated as ACVD risk estimator plus. So that is available online. In the first visit we can estimate the risk, and then initiate therapy, and the follow-up visit also we can reassess ACVD risk using this. And it's available online and can be downloaded as an app store or Google Play. And this is one app I think all cardiologists also should have. And these are the parameters like age, sex, race, even systolic and diastolic BP is included. Total cholesterol, HDL, and LDL cholesterol is included here, which was not there in Framingham risk score. And history of diabetes, smoking, and hypertension, statin, aspirin therapy. So all those things are all included here. And then here, as I have initially showed in the flow chart, so low risk is less than 5%, borderline risk, intermediate risk, and high risk more than 20%. And this is a big chart, busy chart, but we are more bothered about this area where 10-year ACVD risk is to be calculated for 40 to 75 years. Low risk is lifestyle, more than 20%. We know high risk category, LDL has to be reduced by 50%. This intermediate risk, what to do? So we have something called ACVD risk enhancers. We can use these parameters like here, in addition to LDL, we have HSCRP, lipoprotein A, ApoB, ankle brachial index, whether CKD, metabolic syndrome, arthritis, all those things are also included. And then we have calcium scoring also, which comes. I think my slide got skipped. So calcium scoring also comes. So based on that, borderline intermediate risk, we can reclassify them and then treat accordingly. So just to conclude, risk scores like Framingham risk score and ACVD risk score are all practically useful. And nowadays, the most validated thing is atherosclerotic CVD risk estimator plus, and calcium CAC score also can be used for predicting asymptomatic CVD. Actually, these risk scores will assist in assessing the potential value of lipid lowering therapy, whether to be initiated, and also it will motivate patients to pursue lifestyle modifications. Once they know the risk score, at least then they will start lifestyle modification, and then ASVD risk control may be done with that. Thank you.